Welcome to the Caregiver Relief Podcast. I'm your host, Diane Carbo, RN. Today's episode is titled, One Fall Can Change Everything, How to Stay Independent. Because for many families, it's not the diagnosis that changes everything, it's the fall. A fall can take away confidence long before it takes away mobility. It could turn a simple walk to the bathroom into a moment of fear, and it can quietly shift independence into dependence. Joining me today is Jonathan Triber, CEO of Skil-Care, a company that has spent over 4 decades focused on patient safety, mobility, and fall prevention across hospitals, nursing homes, rehab facilities, and homes. Jonathan has seen what happens before a fall, during a fall, and after a fall, and how often families wish they had known things sooner. Today, we're talking about how falls happen, how fear of falling changes behavior, and what caregivers and seniors can do to protect safety, dignity, and independence. Because one fall can change everything. This episode is sponsored by myvitalvault.net, your all-in-one life organizer for aging adults and caregivers. It's designed to help you securely store your essential legal, medical, and emergency information in one easy-to-access place. Because when a crisis hits, being prepared can make all the difference. Join our Caregiver Relief community, a warm, welcoming space where you can connect with other caregivers, ask questions, share stories, and find support from people who truly understand. Visit community.caregiverrelief.com to join now, because caregiving is one of the hardest and most meaningful things you'll ever do, and no one should have to do it alone. And if this episode speaks to you, please take a moment to like, share, or comment. Every click helps us reach more caregivers who need encouragement, resources, and hope. Jonathan, thank you so much for taking time out of your busy schedule to be with me today. I'm really excited about this. Is such a timely topic.
Thank you for having me, Diane. It's a pleasure to be here.
Now, you've been in patient safety for over decades. What made fall prevention such a personal and professional priority for you?
I think it goes back to the origin story, and a fun little history nugget is that Skil-Care is a family-owned company that my father-in-law started now almost 50 years ago. His background as an engineer, he got into this business because he saw the need for various patient safety products for his parents who were aging in nursing homes. And the feeling, which he's told me plenty of stories about in the late 70s, there were a lot of products that patients could benefit from. And so from that standpoint, it really focused on, I would say, 2 major areas. The first was falls management, falls prevention, and fall safety. And there's some nuances between all of those. And then, of course, things like pressure offloading devices, specialty cushions, heel protectors, elbow protectors to combat and prevent pressure ulcers.
Yes. Let's talk about falls. Why do falls remain the leading cause of injury and hospitalization for older adults, despite how common they are?
Oh, wow. It's frustrating. That is a true statement after so many years. And I would explain it in 3 major buckets, that 3 major reasons that converge. The first is regulation by state.
Yeah.
States have determined from a legislation standpoint whether they are, for example, pro-patient restraints or anti-patient restraints. Restraints is a very charged word.
Yes, it is.
I think we need a different name for it, but the gist of it is that there are states that have deemed falling as a patient.
You know what? I will tell you right now, Jonathan, that is really a dilemma we are facing because I have seen it. Patient rights, they don't have to turn, they can develop pressure sores if they want. They can develop pneumonia if they don't want to cough and deep breathe and move around. And I don't understand this patient rights thing to a point. There's a time when I'm an old school nurse. I've been a nurse for 50 years. And one of the things that I find astonishing is patients are being discharged with decubiti, pressure sores on their heels or the bottoms or their elbows. And it's not even documented in the charts anywhere. And they're coming home with no information on wound care or even home care referral at times. Our nursing care, I think, has been really hit. And falls are the number one independence robber of seniors. And one fall just destroys you. I know that they are preventable and there are steps you could take. That's why I'm so excited about having you here with me today,
Absolutely.
because
So
you have
Diane,
solutions.
yeah, you're absolutely. So there's a bright light at the end of the tunnel. But what I'm trying to paint is a picture of that creates a lot of challenges for caregivers.
Yes.
And patient rights and legislation is one piece of it. The other piece, in terms of why falls are still a major, I think, as you said, the number one sentinel event in hospital settings annually, is also I think, poorly managed, holistic view of the patient as it relates not just to mobility and PT and balance training and some of these preventative things that we'll touch on, but also how all of that interacts with medication. And
Yes.
so holistically, this is a problem when we add pharmacological and sometimes necessary medication for elderly patients, especially blood pressure medication, that create reactions within the patient, especially in that nighttime window of a patient who's sleeping, who has to go to the bathroom, and that the pressure equilibration when somebody goes from a lying down position to a standing position and getting dizzy, right? Those are, I would put medication and pharma as another contributing factor here that is, I don't think is often talked about or analyzed as much as it should be. It's people are obviously aware of how medication can impact falls. And then I would add the patient cooperation. On
Yeah,
one hand, you have the states that determine that the patient has, some states say that the patient has a right to fall. I adamantly disagree with that.
I do
Um,
too.
And I guess I missed the other leg of the stool, which is the fatigue that exists within the nursing staff, right?
Yeah.
Battling the uphill battle of states saying you can't use patient alert, alarm, patient alarming devices. You can't use
Yeah.
anything that could be deemed a restraint, which is a very questionable set of definitions and what
Yeah.
falls in that, in my humble opinion. So you have the nursing staff that's fatigued, feel like they're fighting an uphill battle. You have the state legislation that plays a role in this. You have medication and the overall patient care element to it, and then you have patient cooperation. And so patient cooperation comes down, I think of it as just maybe broadly the broad umbrella of exerting one's own agency and independence with poor judgment.
Yes.
That comes down to the patient being instructed, sometimes begged, sometimes strongly worded by the nurse or the physician to say, please don't get out of bed in the
Yeah.
middle of the night to go to the bathroom. Hit the nurse call. We will
Yeah.
run to you and we will help you.
Yes.
And there's a statistic that I don't have, but probably exists about how many times the patient just simply doesn't listen.
Oh, I would say that's really often, having worked in long-term care, assisted living, and home care. I can tell you it's
Yeah.
very common. Yeah.
So patient compliance is sadly at the crux of this,
Yeah.
where we're really now talking not about the physical reasons why a patient might fall, that becomes a medication explanation, et cetera. We're now talking about psychology. We're talking about the psychological drivers of why a patient falls, not because they want to fall, but because they don't want to ask for help, or
Yeah.
they think they can do it on their own, or they
Yeah.
really have to go to the bathroom.
Yeah.
And so they don't want to wait because the nurse takes 2 minutes instead of 10 seconds. So you think about all these things converging at once, and there are just too many variables. And that's why you have a situation where, despite so much talk about falls and so many solutions out there and magic products that people have invented to try to prevent falls or identify falls in real time and all these things,
Yeah.
there is no silver bullet because it's a multidisciplinary
Yeah.
problem, and there are multivariate problem and a multidisciplinary solution.
Yeah. One of the things I will tell you is denial is a very strong emotion, and seniors have them all the time. I can't tell you how many times I've been into someone's bedroom, a lot of for helping a person age in place, and these women have these four poster bed high beds that you need a stepping stool to get in. And I'm like, you either need to get a new bed or cut those legs off. I know, and they are horrified, and it's a battle with seniors to give up anything, and they want to appear to be normal. And it's had detrimental impact on so many because they just don't listen. And or are just closed-minded to the fact that they're aging and may need assistance. It's
You bring up another set of variables, which I think the base care is doing a much better job on mitigating environmental
Yeah,
challenges for falling. Um,
absolutely.
Home-based care, it's still the Wild West. And
It
that's
is.
exactly right. If somebody wants their four-post bed, you can be assured that they also want their throw rug, right, in the
Yes.
middle of the room,
Yeah.
and they want their bed skirts
Yeah.
and you name it. And all of a sudden, you take a lens as a nurse into the risk of falling
Yeah.
between that patient's bed and the bathroom, and you're like, there are about 100 ways this patient can injure themselves,
Yeah.
but they don't want to modify
Yeah.
their living environment. And that becomes its own set of challenges that most facilities have, I think, done the work to design something that tries to balance safety and pragmatism, but also some warm and welcoming and homey type feel. But still, it's not somebody's home, right? And I
Yes.
think that's another leap and another set of issues that
Yeah.
caregivers have to navigate.
So I want to talk about the fear of falling. I'm 70, going to be 73, and I recently, not recently, but yes, recently I was in New Hampshire visiting my son and at blizzard area. And I found myself avoiding going outside, which I do every day walking because I was afraid of falling on the ice because I know things. And I should have bought cleats or something because it's important to keep
Uh-huh.
going outside. I find myself like I'm living in Myrtle Beach right now, and I find myself loving being free, but that fear of falling is real here, and it does change your attitude, it changes your confidence. How does that impact our movement and our ability to stay active?
Ooh, you're talking about the intersection between the physical and the mental.
Yeah.
And it is in healthcare, I could give you 1,000 examples of where that is the dynamic.
Yeah.
Something physical can impact the mental, something
Yeah.
mental can impact the physical. And with falling, I think we all have people in our lives who are in that same boat as you're articulating, right? I can give
Yeah.
you examples of my mother-in-law who is afraid of falling. And that impacts her choices in terms of
Mhm.
what she will do and where she will go. And it absolutely turns somebody who has historically been independent
Yep.
into somebody who is now much more dependent. Um,
Yep.
your question is what can be done about it in terms of tools or regimen. And what I would tell you is the number one thing is easier said than done, but is not to succumb to the fear.
Yes.
Instead, the modifications, which I know my mother-in-law has made as a very personal anecdote or example, is to make sure she is exercising every
Mhm.
day. And the she's fortunate that my father-in-law is still able-bodied. He's 84, God bless him, and she's 78, but they will walk together. So the
Mhm.
concept, which she didn't really doesn't think about, but she's got a buddy system. So
That's wonderful.
that's wonderful. And so anybody,
Yeah.
if the choice is do less and be active less because they're afraid of falling, right? That is to me a horrible dilemma
Yes.
and certainly not the preferred choice. The alternative is some form of buddy system activity, right? Which it could be a friend, it could be a child, it could be a spouse. And my feeling is that the simple repetition, she's not going on 3-mile runs anymore. She's not doing strenuous hikes. We're
Yeah.
talking about walking the dog around the block.
Yep.
But being able to build the confidence back
Yeah.
again, psychologically, where she's not jumping and doing something crazy, but it's small building blocks of confidence.
Yes.
And a lot of it has to do with physical activity and exercise. Walking around the block is great, but you're trying to also convince her to implement things like balance training,
Yes.
um, and using certain things, resistance bands
Yeah.
for some resistance training. You, all of a sudden, I can promise you that the last two things I mentioned become a tall order for most people. Getting out there with a buddy system, or if it's even a physical DME device like a walker, which I know has its own stigma, but
Yeah.
ultimately, physical activity is awesome and great. But when you try to push a lot of people into the exercising realm, even if it's basic stuff, and I can give you my grandmother as an example, because we make Skil-Care some exercise devices. Getting her to use it on a regular basis was torture. She just didn't want it.
Yep.
And explaining it to her, and she had her wits about her and
Uh-huh.
convincing her and trying to tell her, look, if you do this, you will be more confident in your physical mobility and you will be less likely to fall. And we know what happens. Everybody knows what happens when an elderly falls. Bad things is the answer. And it's a question of how bad. Even then, she was resistant. And this comes down to, again, psychological. She has all the time in the world. She's retired. So it's not even
Yes.
like she's trying to do it. So it becomes like you're debating with somebody and trying to convince them about something that's good for them and trying to figure out how to make it a routine
Yeah.
that they can embrace, even if it's 5 minutes for heaven's sake, to just get a little stronger, because the alternative is obviously a greater chance of
Yeah.
falling. And that's the mental part that a lot of people don't connect, is that the fear of falling, yeah, as that perpetuates and potentially exacerbates, the risk of falling goes up.
Yes.
And so trying to explain to somebody who hasn't fallen yet is still so difficult, right? I feel like I'm speaking logic to you, but speaking to somebody, the patient, right, it becomes very challenging. And then especially somebody who has fallen, right, that fear is so real. And
Mhm.
how to get them to do some of these things, I would argue, like many things as it relates to even our own children, right? There's a consistency or an analogy that I'll use, which is people don't want to listen to their parents, right? Kids don't
Yeah.
often listen to their parents, and parents don't often want to listen to their kids.
Yes.
And this is where, again, a whole set of separate challenges in terms of affordability and external care for physical therapists is really where I'm going with this, is to say, look, Dad, we're going to have Joanne, who's a physical therapist, come to the house for an hour a week, two days, 30 minutes, and this is what they're going to do with you. And she's really nice, but you don't have a choice.
Yep.
And that dynamic does work, right? It becomes a, hey, I'm not the bad cop. There's no bad cop here. We love you. We care about you. We want you to be healthy. The same way that sometimes as adults, we need the extra kick in the butt for a physical trainer or to go to the gym or that buddy system with regard to somebody, a friend who's like, hey, let's go for a walk tomorrow, right? That extra motivation. Because most people, including even myself as an adult, and I consider myself a healthy adult, it's sometimes we need the extra push.
Yes.
And anyway, I think I answered the question, but it's complicated. And it comes down to the nature of the relationship between the caregiver and the patient,
Yes.
which could be the child or the family, right?
Yes.
Which is you talk about in your podcast is a $1.1 trillion job annually. And there's so much stress involved with that besides falls and the discussion of falls. You add falls in, most children who are caregivers are like, oh, I don't have the capacity for this to fight with mom or fight with dad anymore. And so it becomes important, but not urgent, if that makes sense. And that also is a dynamic I can talk about. It's a very real risk. The statistics support how bad this is for the elderly. And even if it's not a physical injury, even if somebody is mentally afraid of
Yes.
falling, the impact it can have on their life and their well-being is dramatic and very unfortunate.
It negatively impacts the quality of the senior's life. I've seen
100%.
it before. I want to talk about the most overlooked fall risks that caregivers miss in everyday environments, like the bedrooms and the bathrooms. Those are two places where most falls occur in the home. Can you talk about that a little bit, Jonathan, and what we're missing and what we need to look out for?
Absolutely. So I've done, or we've done, a lot of learning and a lot of our own research on that dynamic. And what I would share is paint a flow or a picture of a patient who is in the bed and the risk factors associated in different scenarios. And here's what I mean. The risk of falling for people of a certain age with a certain body type who may be medicated in a certain way, there are different risk factors and then environmental risk factors. What I'm trying to pinpoint is and get closer to is what is the highest risk moment for a senior to fall? You're
Okay.
telling where they fall, which is important. What I feel we've zeroed in on is while there's risk everywhere,
Mm-hmm.
the
Yeah.
risk or highest probability of somebody falling is at night going from a laying position, a horizontal position, asleep, to a standing position.
Yes.
And what that really means for most people is I use the benchmark of 3 Mississippi.
Okay.
Okay. Because time is a huge variable in all of this, meaning if you start your stopwatch and a patient goes from a laying position to a seated position to a standing position and then takes 3 steps from the bed, that might be maybe 5 Mississippi, but those first 2 steps within that time frame, as I said, you have blood pressure medication, you have just general disorientation, you have which creates dizziness. That hits, and we've all faced it. I felt
Yeah.
that. That positional vertigo or disorientation is maximum within those first few steps from the bedside.
Interesting.
When the patient, if the patient makes it all the way to the bathroom, what becomes fascinating to me is that by then, call it 10 Mississippi, 15 Mississippi, the blood pressure has equilibrated. The patient still may be a little disoriented, but generally, that dizzy spell has passed. If
Okay.
there's going to happen. And
Yeah.
so when the patient is in the bathroom, of course, I look at that as a giant hazard, right? So many hard surfaces that could, somebody falls, the injuries could be severe. But what becomes interesting is that the chances of somebody falling once they make it to the bathroom are actually a lot less. It doesn't mean it's zero. So
Right.
now look at this from a risk mitigation standpoint, and you say, okay, if the acute window for the maximum fall risk is between a patient getting out of bed from a sleeping position and standing and those first few steps, how do you mitigate that?
Yes.
Okay. What's exciting is that there are studies that have been done and are coming out to try to zero in on this because you have different things you would do with the bathroom
Hmm.
in terms of padding and, of course, modifications with grab bars and other things. But the number of fall incidents of people going from one seating or laying position to a sitting or standing position, that transition is the most problematic. And so there's a holistic amount of things that you can do, from environmental changes or products that you can implement within the home, and from everything from cushioned fall mats that exist near the bedside or along the bedside. It's not that people are rolling out of their bed. People are trying to get up out of their bed and they're dizzy and they fall. And why it's multidisciplinary and very holistic. There's not one product that can help protect a patient from injury. There are a lot of products that could really need to be implemented to protect the patient from injury if they fall. And of course, the utopia is fall prevention.
Yeah.
And that's what we talked about half an hour ago, which is still a bit of a pipe dream, because fall prevention, unless you're restraining the patient in some unique way where they're not restrained and an alarm goes off because they're getting out of bed and something kind of restrains them or reminds them, hey, Mrs. Jones, don't get out of bed, the nurse is on her way, type of thing. We're now back to the agency of the patient, the desire to be independent, and the patient who probably should just sit at the edge of the bed, either hit the nurse call, or frankly, the big piece of advice that a lot of therapists and nurses are trying to give patients is, if you want to do it yourself, count to 10 Mississippi before you stand up.
I work with a lot of people at home that have dementia and their loved ones are taking care of them. And it's never realistic for them to fall. And they are the biggest fall risks. You want to wrap them in the
Bubble
air.
wrap.
Bubble wrap, thank you. Want to wrap them in bubble wrap because it's just, and you know what? I have visions of a helmet on, knee pads, and bubble
Yes.
wrap.
And all of a sudden, Diane, now you're in the realm of patient dignity, which is very real.
Yeah.
And how do you balance that? Now, you have patient dignity, which I am a huge advocate of. But then on the opposite extreme, you have state regulations, right? Where you have these patient rights
Yeah.
that ultimately do tie our hands in terms of what we could implement that will keep the patient safe.
Yeah.
And obviously, keeping a patient safe is keeping them healthy. And
Yes.
so it's just complicated in terms of why the states are taking the path that they are, how there can be a better balance in terms of, I would say, just sound judgment that can be made on a patient by patient basis. But patient dignity is also very real, right? In terms of putting somebody in a soft helmet, which, yes, there are some patients who need that. And
Yes.
if they Alzheimer's or dementia, maybe it's more excusable because they may not be fully aware
Yeah.
the help. And then, is patient dignity self graded by a patient who's saying, no, I don't want that because I would feel lesser than?
Yeah.
But, or is it externally imposed?
Yeah.
Is it my judgment on you that I don't want you wearing this type of product or device because that takes away your dignity, even if you don't necessarily feel the same way?
Yes. And it
So,
is a fine line. Yeah.
line.
Yeah.
It comes down to, this is where I say it comes down to the patient, it
Mm.
comes to the caregiver, not just the care environment, but then against the backdrop of sort of state regulations.
Yeah.
And it's we talk with a lot of nurses in states who are very adamant that patients have rights. They have the right to fall. They have the right to develop pressure ulcers. They don't need to do anything they don't want to do.
Yeah.
Those nurses, they're all frustrated because
Oh, I know.
we know what the punitive mechanisms are
Yes.
against health providers when injuries and situations like this occur.
Yeah.
So they're caught between a rock and a hard place.
I've lived it for many decades. Patients wanting to get out and move around and they're not able. I've even been fighting with assisted living. Some of my clients have a loved one in assisted living and they won't let them use alarms. They won't let them use anything. And it's really struggling. I even suggested, because we used to do this, use a low bed, get them closer to the floor so they don't fall. And it falls on deaf ears. That's why I thought knowing about some of your products and what can help my clients stay safely at home even as long as possible, that's important. Because there is a struggle between safety and independence, but how do families protect both? Both assisted living, to me, and forgive me, I know this is going to make heads explode, is the most dangerous of all our medical delivery systems. Okay. And I'll tell you why. It's
Yeah.
based on a social model, not a medical model. And the people there are not trained in any way, shape, or form on identifying changes in the body, like memory care. And you're supposed to be able to direct your own care. Okay. That's not happening in memory care. They're not directing their own care. And the facilities, people are paying beaucoup dollars to have pay their loved one in a unit, but they're not getting quality care. I had this one little lady, she's in her late 80s. Her husband is in his 90s. He's in an assisted living in Florida. And that's how she called me and said, how do I get them to use alarms? And how do I get him? She was going in every day and finding him not having breakfast. Still, it was cold, and he was soaked with urine and stool every day. And she was paying high bucks for this very upscale assisted living. And it's just that they have so many at a high level of, or a look, high functioning or low functioning patients with dementia. Only two aides is not enough to handle all those kinds of patients. And they're not staffing according to acuity levels. So I really have a hard time because it's, if you want something done in assisted living, you have to have a home care company come in. And that's why I'm very curious as what are you doing to help people reduce that risk of fall or the pressure sores that are occurring. That is very concerning to me. I'm really disillusioned with our healthcare system because they keep cutting, and we're talking about getting home care in. They don't even want a nurse to go in anymore. They're not reimbursing for that. So there's all these challenges. And the caregiver, the family caregiver, has more responsibility than ever to provide the care. In fact, we were talking about physical therapy, Jonathan. They're going to an online model, virtual therapy, and it's very real and very soon. And we are also, wait for it, I'm doing a podcast on this later on this month, hospital in the home. And they're going to actually put high acuity patients in the home to be cared for by their family members. And I don't know how that's going to work. I don't, because the family members aren't trained in things. And it's a very deep concern of mine, but it's coming this way. I don't know if you know this, but Medicare Advantage plans make the high deductibles. Right now in skilled care, this is why I'm so curious as what do you have to tell us, because Medicare Advantage plans are charging a copay of $200 to $400 a day out of your pocket. Seniors can't afford that. And families are taking them home. So that's why I thought this was a topic that needs to be addressed and talked about, because family caregivers don't know what they don't know. And I want to, and you are an expert in this, so I really want to talk about what's happening in our healthcare system and offer you as a solution to these fall prevention, fall risk, or other things that what can we do before the first fall or they become a risk? Because this is going to be more of an issue, Jonathan, as we move forward, because patients are going to be in skilled care or rehab. They're going to be sent home.
Yeah. 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 And look, this isn't a product pitch, but we have an extensive catalog and assortment of falls management, falls monitoring, and related devices. We have a very large line of wound care products that, as I said, are aimed to reduce pressure, injuries, but so much of what we're talking about is what wraps around the product, right?
Yes,
It's about that caregiver. It's about the checklist, if you will, of
yes,
here are things that need to be discussed with the patient. Here's how to discuss it with the patient. Here's what the patient really needs to do if they have the wherewithal to make a judgment call and lay it out for them there. And here's what to do with patients that have Alzheimer's or dementia who just can't make the judgment call for themselves. And looking at it holistically, we're not physical therapists, right? We can recommend that a patient look at a physical therapist either at a facility or in the home. Yes, it has added cost, but here are the benefits of that in terms of a weekly routine because it strengthens it. Improving balance is such a huge component of this, but that's not the only thing. And so, from our standpoint, we're a product supplier. We don't provide rehab in the homes. We don't provide home health care. We're not skilled nurses, but we work with all those. It's an ecosystem, right?
yes, it is.
As everybody says, it takes a village,
Yes,
and it does. And so we're a part of the whole entire holistic solution. And that's exciting for us because there's so many talented and passionate people who are on the same mission we are. And so what I can say is we're always partnering with physical therapists. We're always partnering with nursing facilities, home health agencies to as a trusted partner. We're not just here to sell product. We're here to listen to their assessment of the home environment. Here's what we're dealing with, and here's what we're suggesting they modify, and how would your products fit into that? And are we thinking about the right stuff? And we tend to be very collaborative, is my point, because as I said, there's no silver bullet for this. It takes a
absolutely.
lot of people who are willing participants, and even maybe most importantly, the patient. And that often is the hardest in terms of getting compliance or buy-in from the patient to do what's in their best interest.
Yes. Jonathan, how do my clients and my listeners find you?
Oh, we're everywhere. I would say a simple search for us on Google. We also, obviously, they could come to our website, which is www.care.com. And almost all of our products are available on Amazon. Searching for Skil-Care on Amazon, you'll see the whole assortment of what we offer. And then, of course, reaching out to me personally and other key folks at the company, our contact and bios are right on the website. We're always happy to talk to people that have questions or trying to navigate these topics. And so we're always willing to help, even if it doesn't involve our products, because again, it's about the mission. And if
Yes.
we can prevent one person from falling, that's a good day for us. So that's how you can find us.
Thank you, Jonathan, for your wealth of information. Fall prevention is definitely one of the hottest topics right now. And in the next 10 years, it's going to be one of the major topics with the silver tsunami that is here. So thank you for your time. I really appreciate it. To my family caregivers out there, you are the most important part of the caregiving equation. Without you, it all falls apart. So please learn to be gentle with yourself. Practice self-care every day because you are worth it.